Hello everyone, today I noted that most of students get confused between consolidation and collapse. So if it's your case, this video will be helpful for you. So first thing that we need to do to differentiate between collapse and consolidation is to understand what is the meaning of a collapse and also a consolidation. So consolidation is homogeneous opacity in line characterized by little or no loss of volume due to filled alveoli and small airways with the dense material like pus in case of pneumonia or blood, for example in case of pulmonary hemorrhage, or they can be filled with fluid in case of pulmonary edema, or also can be cells in case of cancer. Otherwise, the collapse is also presented with a homogeneous opacity, but it's characterized by volume loss, which can produce a linear shadow. And also, I want to clarify that the atelectasis term, which is derived from Greek, where ateles is incomplete and ectasis means expansion. So atelectasis in Greek means incomplete expansion. And for more understanding the difference between collapse and consolidation, we should know the radiological features of each one. So we will start with collapse, where we have pulmonary opacification, air bronchograms where there is tubular outlines of the smaller airways, silhouette signs, and evidence of volume loss like underinflation, hemidiaphragmatic elevation, tracheal deviation toward the area of collapse, and mediastinal shift toward the area of collapse, hilar displacement, and crowding of pulmonary vessels. And as we can see here in these images, the first image, the patients have a left-sided evidence of volume loss, and it's a case of pleural effusion. And in the second image, we see collapsed right-sided lung because of pneumothorax. And for consolidation signs, we have opacification obscuring pulmonary vessels, silhouette signs, air bronchograms where the longer airways are spaced, and no loss of lung volume. And as we can see, there are two examples. In the first image, we see right middle lobe consolidation in a patient with lobar pneumonia, and in the second one, we see right lower lobe consolidation due to the obscuration of the right hemidiaphragm. So here we have a number of chest x-rays. Please notice the similarity between these chest x-rays. So yeah, you notice that all images are given in frontal view and precisely the right part of the chest, which means that we should look for the horizontal fissure if it is deviated or not. So in these images, they're not deviated except in fifth and sixth image, where it is really difficult to determine it. Which means that in the first four images, there are cases for consolidation, but we should look for more findings to determine the type of consolidation. So as we can see, we're gonna start with the first image where the patient was presented with cough and fever, and in this case it's a lobar consolidation, especially lobar pneumonia. And for the second image, we have a patient with hemoptysis, which means that it's a case of pulmonary hemorrhage. Then the third case, we can see that there are some multiple chronic consolidations, which means it's a case of organizing pneumonia. Then the fourth image, where we see some peripheral consolidation in a patient presented with acute shortness of breath, with low oxygen level and high D-dimer, which means that this patient have some infarction. And the fifth image, we see that the alveoli are filled with some transudate, and this patient is presented with congestive heart failure, which would be more obvious if you were shown the whole image, but it is not. So this case we can say that it's a pulmonary cardiogenic edema. And the last image, at first glance this looks like consolidation, but in fact this is nodular interstitial consolidation, lung disease. So that is so widespread and looks like consolidation, but in this case it's not. It's meant to be nodular interstitial lung disease, and in this case it's a sarcoidosis. Then we have here two images, one in frontal view and the second one in lateral view. And what we can see here in these two images, so we can see firstly that the horizontal fissure moves superiorly, so it's deviated, which means it's not a consolidation case, it's collapse. Then where it's localized, we can see that the right hilum is elevated, then the collapsed lung is dense. We can see that we have a triangular density in the upper lobe, right one. And for adults we should look for a golden sign, and this will sometimes be present when a tumor at the right hilum is the cause of lobar collapse, because in these patients we have a case of the right upper lobe collapse. Then here we have also two images in frontal. First one is in frontal view and the second one is in the lateral, and we can see that the oblique fissure moves posteriorly and medially. So the medial displacement of this fissure causes it to be seen in prowl, and it forms the lateral edge of the triangular density projected over the hair. And we can see also that the right hilum is depressed, Then the right lower lobe pulmonary artery is not visualized, and also the medial aspect of the right dome of the diaphragm is obscured. And the last thing is that on the lateral margin of the adjacent vertebrae is effaced. So here we have a case of right lower lobe collapse. And here, starting with the frontal view, we can see that there is a veil-like density which covers much of the left hemithorax due to the lack of the aeration within the collapsed upper lobe. And then we see that the left heart border is obscured, and also the left hilum is elevated. And we can note that the left cecal sign may be present, where we can see a crescent ecclusency around the left side of the aortic knuckle, which is caused by the overexpanded apical segment of the left lower lobe, positioning itself between the collapsed upper lobe and the aortic arch. Then in this case, we see that the oblique fissure moves posteriorly and medially. So the medial displacement and rotation of the fissure causes triangular density, which is superimposed over the heart. And second thing, we see that the left hilum lies at the lower level than usual, and the left lower lobe pulmonary artery is not visualized, and also the medial aspects of the left dome of the diaphragm is obscured, and the left margin of the adjacent vertebrae is effaced. And here we have the last and final case, where we can see in the frontal view that the horizontal fissure moves inferiorly, and we see also that the right heart border is blurring, where the position of the hilum does not alter, and the density in the collapsed lobe is very subtle. In this case, we have the middle lobe.